We're back for another episode of the Geopolitical View, and I am your guest, Quanda Francis. And today we have Dr. Devi, and I have so many questions for you, so we're going to jump right in. Introduce yourself and tell us about your background.
Sure. So I'm a pain management physician. Basically, I treat a lot of different conditions, cancer-related pain, surgical pain. I treat people who have low back pain and arthritis. But basically, I see people from all walks of life because everybody kind of develops some form of pain or another. And that kind of brought me to a different area over the past couple of years. I started running for office. So I ran for New York City public advocate. And just within the spectrum, I've kind of had some other opportunities. So I teach, I also do medical research. I've written articles and kind of provide medical analysis too for TV. Yeah, so a lot of different aspects of that industry.
Okay, that's great. And as I said, I have a lot of questions for you. But my first question is about common misconceptions about chronic pain. Like, what are some of the common misconceptions about chronic pain?
Well, I think people, first of all, kind of divide things like they think you're healthy or that you have pain and it's like this overwhelming sort of experience where you have pain day in and day out. So there are some people who live with chronic pain that is like that from different diseases. But there's a lot of people who are struggling with this, what we call acute on chronic pain. So just to separate them out, you have acute pain. That's the kind of pain that comes up when you have an injury. So let's say that you go, you fall, you're in a car accident, something bad happens, and you have this, it could be severe, it could be mild, but you have this pain that comes up, and it's probably going to resolve if you wait for a little bit, but the body's going to heal it. And usually you want to try to make it more manageable while it's healing. Then you have chronic pain, which is this unrelenting pain that might be going on all the time. So sometimes that could be related to an autoimmune disease. It could be certain types of cancer-related pain, let's say complications of chemo or complications of surgery, for example. But a lot of people are in between. Let's say they have a chronic condition like back pain, arthritis, even certain types of cancer pain where it's bad at certain times, then it subsides. So maybe there is no pain at certain times, or sometimes it's like really manageable, but certain times it flares up. So I think that people are on a spectrum where they do have these chronic pains, especially as they're getting older. And it's really more a matter of figuring out what's the best way to manage all these different problems.
Got it. That's some great information. So I know you said you get a lot of questions about back pain. So what causes lower back pain specifically?
Yeah, so there's a lot of different causes. I brought a spine model too to try to make it a little make sure I can show it properly. Okay. So let me just say first, before we look at this, if you have low back pain, there's always a few questions that I ask people just to make sure this is not dangerous. So if you're having low back pain, you're having fevers or chills, that could be an infection in the back. That's usually somebody who's just had a procedure in their back. Okay. Somebody who's got back pain and a headache could be meningitis, somebody who's diabetic, some other reason to have an infection. You got to be very careful. So fevers, chills, and back pain is a bad sign. Somebody who's got signs of paralysis. So they suddenly became incontinent. They suddenly feel like they can't move their legs. Things like that are a different category. But let's say that you've got your run-of-the-mill sort of like you were bending over to do something, you were at the gym, you're doing anything, and then suddenly you felt like something gave out in your back or something happened, you felt immobilized. That's a lot of what I see. So, that's the kind of back pain that we're talking about here, or back pain that comes on after you've been standing and walking for a long time. So I'll just show you like a model of the spine. So just for reference, when you press on your back, like when you press back here, what you're feeling is this area back here, these pointy areas in the back of your spine, the very back. Mm-hmm. And then the front of the spine, which is the back of the belly, has these different bones called the vertebral bodies. And in between, you've got these discs. Those are the cushions of the back. So when people talk about herniated discs and things like that, what they're talking about is these cushions are kind of not so cushiony, first of all, which happens as we get older. Okay. And then they kind of push back, So what are they pushing back on? All of this is armor. The bone is armor protecting the spinal cord, which is in the center. And the spinal cord has all these different branches that come out and go down the legs that let you walk and do different things. So if the disc hits one of those nerves, you can get pain going elsewhere, like to your buttock, down your leg. When people are talking about sciatica and stuff, that's what they're talking about. So these discs getting wear and tear, becoming herniated, kind of like a flat tire in the spine, that's a common cause of back pain. The other thing is along the side, you have joints, which joints are any area where two bones are near each other. If those bones are not smooth, like very smooth, they become jagged, if they're kind of like, think about them as like rusty and stuff. But if they're not smooth, then people can get this pain from that friction, and that's arthritis pain. So the way sometimes you can separate them is if you're sitting for a long time, if you're bending, you're twisting, you're lifting your baby, you're lifting a suitcase, you're doing the dishes, you're sweeping, vacuuming, that's probably disc-related pain when it comes on. If you're somebody who's standing and walking for a long time and you feel like standing is really bothering your back, that could be arthritis-related pain. So when you go to the supermarket, sometimes there are folks who are much older, they're kind of bent over like this.
Yes.
What they're doing is they're trying to open up this space. This model doesn't bend, but they're trying to bend this down and open up the space between the joints so there's less friction. So that's probably arthritis pain. And then, of course, anything over the top of this is muscle. So like muscle can get pain, too. So sometimes people think like, I pulled a muscle or whatever. That can happen, but more often you have something going on with one of these underlying issues, I would say, and then it refers to the muscle. So then the muscle causes pain also.
Okay. And what causes arthritis, since you mentioned that
Yeah.
Mm-hmm. What causes arthritis? Like what's a main cause of arthritis?
So actually nobody knows the 100% exact cause, but there's a lot of things that go along with it. So as we get older, we get more wear and tear in the joints. And then arthritis can refer to two terms. So one is the mechanical part, which is like the friction that I was talking about, that the bones get closer together. Like if you think about the knee, the thigh bone, the leg bone, they come closer together and then there's friction. But then there's also inflammation. So inflammation we won't see on an x-ray. We're not going to see it on these other tests that the doctor orders, but it's where, like when you get a swollen ankle or where something turns red, all those things that we see can happen inside the body also. So sometimes people are talking about inflammation and they call that arthritis too. Mm-hmm. So what people have found out so far is that as you get older, there should be fluid in there, kind of like lubricant in the joint so that everything moves smoothly. And when you reach like your late 30s or so, you lose the ability to make that water-like lubricant. It just, something goes wrong. You can't really make it for the cartilage and stuff. So what happens is the body stops making as much of it and you get some wear and tear related to that. Then what happens is it realizes that there's a problem. So it starts ramping up how it makes this cartilage, but it's not making it in the right form. So it starts making an abnormal cartilage. Cartilage is the padding that's in between the bones. Then you make this abnormal cartilage and you get some damage related to that as well. And then finally, as you get older, like we're talking about the 70s, 80s, you have a problem from both, not having the normal cartilage and also having this abnormal cartilage. But we don't know what exactly causes this process to start. We just know that that's the end result of this.
So we're going to shift a little bit. And I have a couple of questions for you about in terms of like, well, how have you used your platform to increase attention and resources towards the treatment of chronic pain?
So I've tried in different ways over the years. Actually, when I first got started, this is when I was 18, I joined a research lab. So when you start out, you want to make a difference in different ways. Like I had actually been sick when I was 16, not necessarily with chronic pain, more the acute pain. I'd been hospitalized in the ICU for some time. And then when I got better, I thought, how do people recover from these sort of catastrophic injuries? Like, why am I still here? Why am I okay? So I got involved with research and I thought, you could help a person, like one person, one by one, if you're treating them maybe as a patient. I wasn't a doctor yet, but I was thinking that. But I thought research, you have a capacity to treat people on a large scale. So that's why I got involved in that. Then teaching, I started thinking the same way. So I got involved in teaching. And then, and first I used to teach kids like in 6th grade, 7th grade, 8th grade, like, this is in Chicago. So there's an area called Cabrini Green, which at that time was somewhat dangerous, but I used to teach there. And then over time got more involved in other activities. So between the medicine, I think I've treated now like probably 20,000 patients, something like that. Yeah, it's a large number.
Yes.
But then with it kind of expanded. So I started writing more like for the public. I decided why teach only at medical schools, or I started teaching faculty also. So see, I do pain management, but just because if you teach people when they're in medical school or when they're in training, that's one thing. But what about the person who's been in practice for a long time, who's treating another patient? That person may not be most up to date about what's going on with pain and what to do. So I got involved with teaching faculty, and then most recently running for office. This is like a whole new world, sort of, not just in the medical world, but I felt like it related quite a bit because so many of the problems that we have are related to quality of life and health. I see people from all walks of life coming in as patients. So, I was able to kind of link the two, I think.
Okay. Well, since you did mention your run for public advocate, I'll sort of shift a bit and ask you some questions about that. So what motivated you to run for public advocate?
Well,
New York City public advocates, because it's a geopolitical podcast. So New York City public advocate. What motivated you to run?
It was my own personal experience. So just like when I was sick, when I was 16, that's what motivated me to become a doctor. I felt like it was I had always been interested in getting involved in politics, but it's sort of one of those things where you're like in a state of inertia, like, oh, I don't know anything about this. So I was kind of going around like that. I felt like I had some background from talking to the patients about a lot of different aspects of the city, but wasn't necessarily going to do anything until COVID hit. So what happened with COVID it was a combination, I would say the whole experience, but like to make it more concise, essentially when COVID hit, we're sort of faced with this problem where we had a daughter, or have a daughter, but at that time she was 2. Daycare closed. So me and my husband had this sort of problem where, daycare's closed, sounded like not necessarily a huge thing, but who's going to watch her during the day because we're both working. And for my actual job in pain management, I do a lot of procedures like nerve blocks, spine injections, all of this stuff. I can't bring a toddler into the operating room or surgical suite. Like that's just not feasible. So I can't be the one watching her. But then, for him too, he couldn't watch her necessarily 24/7 either. So we had this significant problem there. So most people, what they were doing was staying at home, but like this position, I can't stay at home. And if I did, what would be the consequence? These patients that I take care of, they don't have COVID, but they have cancer, they have autoimmune disease, they have all these things. If I wasn't there, they would have to go to the emergency room to have their pain treated, because the whole reason they're seeing me is because their regular doctors cannot manage their pain. That's the problem, right?
Yes.
We had to make this difficult decision to send her away because we couldn't watch her. So she was gone. We thought it would be 2 weeks because remember, it was that initial 2-week lockdown. Mm-hmm. But we didn't see her again for 8 months. And because she was 2, she basically forgot who we were, essentially. Like she thought we were these kind of cartoon characters who lived in the phone. So that was very upsetting to her, but she was sort of doing okay with my parents, who of course love her so much and like we're taking care of her. It was very challenging for us. Then, we're trying to take care of the patients. But even for the people who work for me, look, I'm a doctor trying to do this, but a lot of the college students, they're trying to like get by. They have to deal with the challenges of the subway. The crime was rising. Not everybody was reporting it, including me. I was assaulted on the subway too, but like didn't report it, because what are you going to do? I don't know who this is who did this. I don't want to necessarily put myself more at risk by going and interacting with more people to report it. For what purpose, And I was pregnant at the time, so I was particularly afraid. Oh, I also got pregnant during this time. I was also afraid for the baby. So all of this was a challenge for the business. So I was thinking about that for also other small business owners and everything else, and students, other people who are having to work like as essential workers, which I don't love that term, but whatever, that was the term we were using. And then finally it all culminated. The baby was about to be born. So we brought back my 2-year-old because I thought we don't want her to feel like she's replaced by this new baby. So maybe I'll take some time off. Maybe things will get a little better. We'll try to do telehealth or whatever. But either way, I'm having this baby. So then we brought her back. And of course, just the way things work, my husband got COVID right at that time. He immediately got hospitalized, couldn't breathe. I had to call 911. And, and then he was in the hospital for almost 2 weeks, but we didn't know, is he going to be okay or not okay? What's happening to him? He was delirious when I called 911. And then I got COVID. So then I started having these like contractions out of the blue, but we had a problem because this is all before the vaccine. So if he's hospitalized and I get hospitalized, who's going to watch the 2-year-old? So of course I asked if I could just get the 2-year-old hospitalized with me and we'll all be hospitalized together because she has COVID. Mm-hmm. So they said, no, she can't be hospitalized because she's not sick enough. But then when I called the city for help for her, who's going to watch her, they said, like, this sounds like a dangerous situation. Maybe we should call Child Protective Services. So like to take her away from us. So to me, okay, let's just make it like a long story short, we survived and everybody ended up being okay. My husband was okay. But I was thinking I was going to do a home birth because I wasn't going to let CPS take her. I was very worried because I had preeclampsia, which is high blood pressure pregnancy earlier. So I didn't even know if this baby's safe. We all have COVID. I'm like, he was delirious. I called 911. Am I delirious? Who knows? No one's here to call 911, but I'm not going to let the city take her from us. And then we don't know, like, if something happens, she'll be an orphan or whatever. No one could really come at first because it seemed like unsafe. But all of that highlighted the problems in the city for me. And then one thing led to another. I was like, there has to be a change. I may not be the perfect person, but I'm going to try to do what I can.
Okay. I mean, that was a lot because you were talking about trauma and then a breakdown and sort of the infrastructure in terms of city services and the best way to support, just residents here, especially in a pandemic. So, that's an interesting way of looking at things. But how did your run? How did your run sort of affect your run for public advocate? Like, how did it inform your political and campaign, initiatives? Like, how did it inform your campaign platform?
Well, my platform was actually, I kind of looked at it as it should be 3 principles. Whatever the issue is, what this city is missing is transparency, fairness, and consistency. I shouldn't say missing completely, but where I felt like the important issues are those 3 things. So part of the reason I think that there's a lot of division is because it's so unclear what's going on. I felt that was especially true in COVID, just being both a healthcare provider and with trying to treat the patients, trying to figure out what's going on, even for my own employees as a small business owner and stuff. Felt like it was very hard to get any information about what's going on. And then without that information, it's very hard to act effectively. So I thought transparency is the core of the platform, that people have to know what's going on. Then fairness, so even with the experience that I told you, part of this stuff, the thing that, it's not the outcome. It was the fact that when someone's asking for help, like they're asking for help because, that's what they need. They don't need a punishment at that time, someone to take their child away, right? So, you've got to have some kind of overlook, or outlook, where you're trying to help people. It may not be the way that they want or whatever, but there's got to be some fairness to it. This doesn't make any sense. Otherwise, people will be terrorized by the government services, and that's not a place that you can live. It's not going to be successful. Then on top of that, consistency, because you can't have and this is all of this is true in medicine too. So I don't think these are new principles, but you have to have, for example, what I was saying about back pain. You can't have a person go see the primary care. They walk away with Advil and a heating pad, And then the same person goes, if they happen to see a spine surgeon first or book an appointment with an orthopedic surgeon, they walk away with a lumbar fusion or something. That doesn't make sense. There has to be some kind of guiding sort of algorithm or principle that, no matter who you go to or whatever, like everybody's following some general algorithm that makes sense. And it has to be the same from one person to another. Not every outcome. I'm just talking about like the mentality, like what you're using to decide how you're going to do things. And then if you have those principles, you can apply them to any issue and kind of come to some kind of agreement, because we're trying to do the best for the city and work together, not divide ourselves.
Okay. So we have two things, and I ran for mayor, so a lot of the issues that you're talking about, just with information synergy in terms of agencies working together, it just it was just not a well-managed machine. But we were also in the middle of a pandemic that not many people knew about. So when we there's that balance between how involved the government is going to get in everyone's lives. Like in your situation, it was very personal. You were dealing with a lot, and in that particular situation, there can be there can be resources that the government provides, right? But when are you in a situation where there's too much involvement from the government, right? Yeah. And so and which puts you in a situation where, again, now the government is involved, and now they're trying to make decisions for you, your children, and your bodies, right? So there's that. So that was the reason why I asked that question, because, again, we had the mandates. I was in opposition of the vaccine mandates to keep your job, right? Yeah. And only because, with me, with my background in training, there just was not enough information for me. Like, I'm a researcher, right? So if I'm looking at the research, or I'm looking at what information is going into making these decisions, I have to feel comfortable with that information and how it's put together. And if I don't feel comfortable with it, not saying that it's inaccurate, or if it's not about the accuracy of it. It's just about whether or not I feel comfortable with it. If I don't feel comfortable with it, I do not want to, on the behalf of the government, say, I'm going to require you to get vaccinated. But however, there is that fine line between, with government overreach. I believe that the government is there to serve the people. The government is there to serve the people. So, which leads me to my next question, because I just had to sort of jump in because I was listening to you, and I'm like, the role of the public advocate, I believe, first and foremost, should be to make sure that people have the information that they need to make informed decisions.
Yes. Well, I agree with you. I was going to say, before we move on to the next question, I agree with you. I also oppose the mandates, because I said, as a physician, we're for informed consent. So there are plenty of times where, I might choose one way to manage something, or think that might be a way of doing it. Patient might want to do something different, but it's not our job to impose our views on people. It's to give them the information, the risks, benefits, and alternatives. So,
and let them make the decision for themselves. Like, exactly. I would recommend it, but I won't mandate it, which is two different things.
Exactly. And I think also the timing of the mandates, the time that the mandates came into place. So let's say if everybody believes like the vaccine was helpful, let's just say that, like if they believe that, they were getting it and things were improving. So there was not really a necessity to impose this on people and then have such a harsh punishment on the people who didn't get vaccinated at that time. I thought that also was another thing in terms of fairness and consistency, where the city, here in the city, so they had the mandate, which is one thing. So, okay. But then if you didn't get the mandate, you had such a harsh punishment where everything that you had done maybe before that is almost erased. Like all your benefits, if you worked for the city, et cetera, are gone. All the years that you might put in are gone. And then on top of that, what I thought was really strange was that the numbers were improving. So there's no reason to have such a harsh situation imposed on people. But we had two different things going on. Like if you got the vaccine, then you could benefit from all these different activities, go out to restaurants, go do whatever, have these outdoor concerts, do all these things, which creates the impression that everything is significantly better. It's safe for us to reopen. It's safe for us to do stuff. But at the same time, if you didn't, then you can't. It's too unsafe. It's so unsafe here. You must have the vaccine. So to me, this looks like two opposing messages being said at exactly the same time, which I think also adds to the division. Like, you need to have a consistent message. Like, what are you actually trying to say? And, then the actions have to also support, like, just from, politics aside, just from a logical point of view, you have to have a message that people can hear. It can't be two different messages at the same time and then two different actions at the same time.
Got it. So, yeah, that's a very interesting perspective. And I'm going to shift a little bit. So we're, still talking about city services, but, mental health disorders and substance use disorders. How do you see them being addressed to improve public safety?
I think that, first of all, like, there's the medical aspect and then there's the legal aspect. And I think somehow it hasn't been teased apart as effectively as it could be right now. So me as a physician, working right now, I'm mostly outpatient, but when I worked in the hospital, there are actual ways that people manage mental health disorders because, you have to worry in the hospital, like, and when I say help, obviously, like you said, prevent overreach even within the medical environment too, but like prevent overreach, but still try to help people to the best you can. But you have to look at the person who has a mental health disorder and figure out what can you do to address their concern without imposing on others. So someone can't just wreak havoc in the waiting area and threaten all the employees and do all this stuff and then say, oh, they have a mental health disorder, so we're just going to give it a pass. You can't do that because you have to protect the others as well. So there has to be sort of a balance between offering the medical care so people who want medical care can actually be able to utilize it or have access to that and stuff and be able to diagnose what truly is a mental health medical condition versus something else. Because there's also, I would say, sociopathy where you that you've done something wrong. You just don't have any guilt or remorse about it. You're okay with it. It's not a mental health disorder. That's different. A mental health disorder is really a medical problem, but maybe could be corrected. But regardless, you have to protect the public.
So I'm going to not really shift a bit, but I have a question in regard to that because the current mayor has this mandate, or do you agree with the, I guess, with him institutionalizing individuals that the police department may consider to be having some sort of mental health episode? Because I don't really see any guidance on that. Like, if I don't see how police officers are able to sort of make those decisions about, as you said, because there's a difference between the two, who is actually mentally ill and versus someone that's having some sort of psychotic episode, which may or may not be associated with a mental illness, but if they're having a psychotic episode, it is associated with the mental illness. But do you agree with the policy?
No, I mean, well, as we said, so I'm generally against this idea of mandates to begin with. I think that, people, especially these universal themes where everybody has to do something, I feel like they're not effective. Things have to be looked at on an individual basis, although you can have some general guidelines so that people have something to use to operate, But first of all,
you disagree with that. You agree with it or disagree? I just want to make
sure. I disagree with the mandate.
Okay.
I disagree with the mandate. But I was just going to say, like, I think that, it is helpful to have the police educated about, mental health disorders. I mean, I think actually, one of the controversies when I was running for office, I thought that there should be more funding, at least for the police, because not necessarily to punish people or anything like that, but I think people need more training to be able to deal with mental health disorders. Like, if we have a problem, let's say in the hospital where, let's say people were dying in the ICU at a higher rate or something was going wrong there, we're not going to punish the ICU by taking away the funding and then more people might die. We actually would look to see, does the ICU need more staff, more capable staff? Do they need more education? What's wrong here? Why are people having such bad outcomes at this place?
Okay. So I want to interject for one moment with that analogy. So as a physician, would you want to know why so many people are ending up in the ICU to begin with? right? Before we even get into the overload, right? Because if we don't have to see as many patients, right?
Yeah.
Then that sort of will solve some of the problems that will occur in terms of, again, just the influx and how we're treating them and the effectiveness of the treatment. Reducing the number of patients, coming in is important.
Of course, prevention. Yeah.
Okay.
I mean, so when I say more funding, I don't mean at the expense of necessarily, other things that might help folks. But I do think, like, if you have police making any decisions and they're looking at folks, they should be able to tell the difference to some extent, not to make the decision, but just to have some knowledge about what is an actual mental health disorder or who could be suffering from a psychotic episode. Even if we take out any aspect of crime, sometimes people who are diabetic with high or low blood sugars can look like they're drunk, so to be able to tell the difference, is this person drunk or do you need to immediately get medical attention, like call 911? It is important, I think, for people to have this ability to recognize emergencies in all different forms.
Okay. So that's a good point. And in terms of when you talk about the police department, I think a lot of people, or that statistic about how many officers are taking their lives due to suicide is sort of being unreported. So when we talk about adding more funds to the police budget, because I'm not sure if you know that I work for the police department, but my background in terms of accounting, right? Budgets need to be managed. They need to be managed effectively.
Yes.
And so with the very large budget that the police department has, I believe that it is important for officers to be trained effectively. Yeah. But there's a climate problem. There's an institutional problem. There's a systemic problem that is going on in the department before they step foot and they're out in their policing. And that has to be addressed as well, because that's affecting public safety. That's affecting how they police communities. So I think that, what you said is accurate. I mean, it's correct in a sense that they should get more training. However, we're talking about some people that only need 60 college credits, right? Yeah. To become an officer. And these individuals are making decisions about who should be institutionalized versus who shouldn't. They're someone with 60 college credits or more, because sometimes you do have some officers that are more educated, but that doesn't mean that they've had the sort of training that they need to accurately be able to detect someone, accurately assess whether or not someone is having a mental health episode. So if, in your opinion, if you were public advocate, what specific training protocol would you put in place to allow someone with 60 college credits, right, to accurately or come close to accurately identifying someone that's having a psychotic episode?
Well, I think that's where we disagree, because I don't think that, so I don't agree with someone with 60 college credits necessarily institutionalizing someone with a psychotic episode,
That's what's happening, because as the individuals that are more educated are not the ones on the street, right? That's just the patrol cops are the one that are interacting with the public. And the requirement is 60 college credits. So we're asking them to identify, right, these, someone that's in distress. And this is something that a doctor should do. That's you may not be able to accurately identify someone.
Yeah, usually it's psychiatrists.
And I may not be able to, accurately identify someone, which is all of my, research training on these. So, but we're talking about, again, and this is not to say that they can't be trained to do so, but my issue is with it being the people being institutionalized.
Yeah, I think we're in agreement on this. I don't really see us disagreeing, because I do think someone with 60 college credits, or I'm not trying to harp on that, it's not that, but I think anybody can be taught to recognize an emergency, a medical emergency, like we start even with people who are sometimes like in 7th and 8th grade, trying to teach them like this person could be a diabetic, this person could have this problem, this person has chest pain, call 911. So all of these different things. Psychotic episode, most physicians would consider that still within the realm of medical emergency. Why is this person having a psychotic episode?
So would you suggest that there's a task force and certain officers with I'm just trying to ask, like, if this is already occurring, so like if you have recommendations, right, because there's no way to really make this better, but sort of minimize the impact to individuals that may not need to be institutionalized, like just what do you believe there's a training protocol that, or you just don't believe don't believe that it's a good practice at all and it should be just done away with? They should go in a different direction.
Yeah, I think, so I think because I come from a different field, I don't necessarily start out with this idea that people should be making these decisions out on the street, like even within the hospital, I don't make these decisions. Like, even if I'm in the hospital, we call psychiatry if we think there could be some kind of issue. Like, we call specialists in that area, because even though I might treat a lot of people being in chronic pain, my field, I might see a lot of people with depression, anxiety, all kinds of things related to their pain, but I still don't make those decisions. I defer to the people who have expertise beyond my expertise in terms of that. I do feel like I have the ability to determine what's called capacity. Like, can they consent to a procedure? Okay. Do they understand, like, if they take this medication, there could be some good, there could be some risks, so I feel like I can make those decisions. But what I think is that, people who are out on the street in any kind of first responder type situation, public safety role, should be able to recognize if you're in public safety, is something unsafe, and then bring the person potentially to a place where that decision can be made by somebody who has much more expertise. There should be sort of like a pyramid type,
okay.
If you had to visualize it, but not that somebody who may not have much expertise or training should be in that area should be making these life and death decisions about it. So, okay.
Well, that's a great recommendation. So that's a great recommendation. Like, if they just decide to keep this going, that's a great recommendation. So I'm going to shift a little bit, right? Get on a lighter topic, but you go in General Hospital. Can you tell us about that experience? Like, when you went General Hospital, and just like about that experience?
Oh yeah. I mean, it was a really long time ago. So I was in medical school, but I wasn't a doctor yet. And this was, now I'm like dating myself, but it was like a long time ago. It was like when it was like World Wide Web and people were putting all their stuff on the internet. So, I was actually able to get the contact information and everything, call the studio. And I was trying to get tickets for my grandmother, who was a huge fan of the show. So basically, and I used to watch with her all the time. So I was like, okay, let me see if I can get her tickets, because I'd finished medical school a little bit early. Like, usually it's a matter of finishing all these like what's called clerkships, where you rotate on the hospital floor. So I thought, okay, let me see, this will be fun for us to do together. Well, the person didn't know what I was talking about. There's no studio audience. And of course, I'm just like some random person calling with this. So they're like, you cannot come to the show. Don't know what you're talking about. Like, people here have to have a job on the show. And so, I was like, I don't know what motivated me to say this, because I'm usually pretty shy, but like, especially at that time. But I was like, well, what kind of job? Is there a way I can get a job on the show? So I didn't even know who I had reached. But then they were like, what? Okay, send your resume and a photo. So I'm thinking, like, maybe I'll have something like, I don't know what kind of job, but like, behind the scenes, maybe something. So I sent my resume, which is all like, I've done research on Alzheimer's. I worked in the lab, like with the microscope and everything, I'm like,
you're like, your acting resume.
Yeah, so I don't know, but it was such a shock. Like, a week or two later, I get this call, like, okay, we got your resume. They must have been thinking this person's crazy, because it was such an odd resume for the situation. But they were like, okay, you can come on, come out here. So of course I'm not in Los Angeles, but I decided, well, if this is a show, like, there's no way I'm not going. So I fly out there and everything. And actually, it's funny because it was just supposed to be like one time. Everybody was actually very friendly because they thought I was like playing a doctor. So they thought it was funny that I was going to ultimately become a doctor.
Okay.
But it's the same principles. If you're on time, you do the job, you do all these different things. I went back several times for years, like every time there was a break during residency or anything else. So I went there. But what was, I don't know if you watch the show, but there's like a main character, Sunny. Okay, yeah.
Well, I did. It's been a long time, but like I grew up in that household.
Yeah.
Like my mother, she worked for the city, but she would record the stories.
Yeah, I would too.
So she got in, she would like watch everything that she missed. But so I remember Jason. Yeah, I remember that.
So I have a funny story. So basically, like, they told me, like, okay, I'm supposed to walk around the nurses' station and stuff. So I'm trying, so they were redoing the scene. This is not about me. This is just like I'm there, but I'm walking around, and then I see Sunny kind of in the, behind, he wasn't in the scene, but he was kind of like walking behind a camera. So of course, I'm like, oh my God, while I'm walking, then I stop, and then he like smiled at me or winked at me, but I just stopped like in the middle of the whole thing, and I'm just staring at him mesmerized. And then all of a sudden I hear cut, and then they're all like looking at me. I was like, oh my God. And then this stage director came up to me and was like, what is going on? You can't just stop in the middle of the scene and just stop and stare at them talking. So I was like, oops, sorry, but then it was embarrassing too, because he looked at the whole thing and started laughing, but what are you gonna do? But then later he was very friendly, and I did get to talk to him several times after. Yeah.
Nice. But my last question for you, well, I didn't ask you, right? Because I did like shifting a bit, but I did not ask you. So you ran as a Republican. It's like, are you a Republican?
Yeah.
Republican ticket.
Well, I am a Republican, but I think like this. So I feel like sometimes when people think of a party, they think of like every single thing that's, let's say, propagated by the media. But I would say the thing that makes me a Republican, which I find is universal among Republicans, is that we're like against all these taxes necessarily being, used in a certain way. So when we're talking about government overreach and stuff, like I'm all for things that kind of, fit that balance, I would say, like less bureaucracy, but still kind of high yield in terms of improving things for the public. But on the other hand, I do feel like living in New York City, there's a tremendous amount of taxes. I'm not talking about like big business. I don't have like a big business or anything like that. But I do think for the amount of taxes that we pay, we should see the effects in terms of what we're getting, in terms of public safety, in terms of the businesses we attract here, like the education for our children and stuff. I'm not seeing it. So then, what you were talking about with budgets, I think that's where the key comes in. Like people need to have the transparency. Where is the money actually being spent? Because it looks to me like there's a lot of money being charged in taxes. People are paying it, some of them, others are leaving the state, or leaving the city, which is another big problem. And then a lot of that money, it's unclear like where it goes because it's not totally obvious. But sometimes it's actually being, seems like it's being funneled to other folks that really unclear how that's being used. Yeah.
I don't know about that, but
yeah,
I could say I could agree that there is a lot of mismanagement and inefficiency within the government, and that is one of the reasons why I decided to run for mayor of New York City, because again, we need smarter people leading the government.
Yes.
And for the budget that we have, and just, my platform was about making, New York City the smartest city in the world. It's interesting. I see, the chat and how we're utilizing artificial intelligence. I'm like, my God, I don't believe they have a clue as to the type of city that we can have.
Yeah.
If we have, someone like me leading, at the helm. So, but my last question for you is about advocacy. how do you see the future of advocacy for treatment of chronic pain? And how can individuals and communities get involved in terms of making a difference?
Yeah, so I think, chronic pain, like I wouldn't group it as one condition necessarily. I think it's a lot of different medical conditions. Pain is one aspect of it. But I think where people are seeing it the most is like with the opioid crisis, right? Because a lot of times, opioids on the surface are being prescribed like for pain, but then depending, they can be funneled in different ways also. So I would say the biggest impact probably is at least to understand like maybe with at home what might be a sign like that if you are exposed or see opioids, like what could be an issue. So if a person has chronic pain and they're using opioids or they're prescribed opioids, I'm definitely talking about prescription, but if they're prescribed opioids and they're using this to manage and they appear to be getting better. So usually like if we see people on opioids, I do mostly procedures, but just, we see this like from surgery and other things too. If they're getting better, meaning they're able to walk more, they're able to get dressed, they're able to groom themselves, they're doing all these different activities, they're, going to their appointments, they're able to do physical therapy, things that would otherwise be painful. So using the medication to have some kind of functional benefit, mobility benefit, all of this stuff, that's one thing. But if they're using opioids and they seem to be getting worse as a result, so not functional, whatever it is rendering them not functional, then that's really concerning. So in terms of like community, keep an eye out if you're seeing people sort of deteriorating either with opioids or they're not keeping them safe, their children are having some kind of potential risk of getting close to the opioids or whatever else. Like you want to just kind of keep up this public awareness about what's going on, because now it's less prescription opioids and more synthetic fentanyl and stuff. But any sign of this, any kind of potential exposure to opioids, the things to be aware of, people don't always know the sign of opioid overdose. It's usually an accidental overdose. So I'll just say those quickly. If somebody seems really sleepy and sedated, they're hard to wake up, maybe they're breathing a little slowly, like how would you tell if you put your hand in front of them or something like that, their nose, and you don't really feel a lot of air, you don't see their chest rising much, seem a little confused. Sometimes it can just be sleepiness, but you think that they've been exposed to opioids, they're not really waking up, that's a reason to call 911. If they have Narcan, that's, sometimes if it's prescription, they've been given Narcan too. That's a reason to inject it. There's no reason to hesitate and think, oh, let this person sleep it off. If they've been using opioids and alcohol, opioids and another class called benzodiazepines, which is Valium and stuff, inject that Narcan or call 911. So like if someone's drowning and they are losing oxygen, they'll usually struggle because they know they don't have enough air. It's going to be a huge splashing, thrashing, all kinds of stuff. With opioids, they don't realize that their oxygen level is coming down. So they look very peaceful and like they're sleeping. But then the oxygen level could get so low that, once it's too late, then you might see some struggle, like this person's dying. But you got to act before that.
Okay, great. I said this is my last question, but I have one other question for you. With the current public advocate term limited, are you going to run again?
I wasn't planning to. No, I wasn't planning to, but I was getting back into my regular life. But when you ask me these things, it's like I thought I'd be like really calm and collected. But it reminds me all the reasons that I got involved in the first place.
Okay. So you haven't made a decision yet.
I would say that, but it does remind me that I do. I am in medicine, but I do feel passionate about a lot of these things. It's like you said, we need some changes.
Thank you for joining the show. And we're done here.
Okay. Take care, Kwanda. Thank you so much.
Okay.